Okay, hi everyone. Welcome to today's Partnering with Schools for Mental Health Leaders webinar series. Today's webinar is on overcoming challenges to community school partnerships. So I am coming to you from the Southwest Mental Health Technology Transfer Center, which is funded by SAMHSA. This is our standard acknowledgement that we're funded by SAMHSA. And as you'll see in the upper left corner of your screen, we are joined today by the National Center for School Mental Health. The Southwest Mental Health Technology Transfer Center is part of SAMHSA's Technology Transfer Center Network. They're TTCs. And the purpose of our technology transfer centers is to develop the healthcare workforce that deals with substance use disorder and mental health disorder prevention, treatment, and recovery support services. We help people and organizations incorporate effective evidence-based practices into substance use and mental health disorder prevention, treatment, and recovery services. We basically work to bring research to practice. What works? Let's get that out in the healthcare workforce. So this is the TTC umbrella, and you'll see under that is the Addiction Transfer Technology Center, Mental Health Technology Transfer Center, Prevention Technology Transfer Center, and the new SMI Advisor. The SMI Advisor is one-on-one consulting for clinicians who work with clients with serious mental illness. And what you should take away from this slide is that you all have access to all of these TTCs and the SMI Advisor in Region 6 for assistance with evidence-based programs for your workforce. So today's topic is overcoming challenges to community school partnerships. We're so excited and honored to have two faculty with us from the National Center for School Mental Health who will present this webinar today, and I just want to read their bios to you briefly. Dr. Jill Hack-Bonenkamp is an assistant professor and core faculty at the National Center for School Mental Health within the Division of Child and Adolescent Psychiatry at the University of Maryland School of Medicine. Dr. Bonenkamp has extensive experience in school mental health research, policy, and clinical practice at the local, state, and national levels. She works with individual school personnel, district, state, and national leaders to advance high-quality school mental health. Dr. Bonenkamp builds on multiple years of direct clinical experience as a school mental health clinician in urban, suburban, and rural school districts to inform her research and policy work. Her research focuses on behavioral, academic, and school safety outcomes of school mental health service provision, mental health training for educators, and pediatric primary care providers, and ways to increase access to evidence-based mental health services for youth and families. Dr. Scardamalia has extensive experience working with high-needs youth and their families as a school psychologist in both the public schools and juvenile services. Her research focuses on the intersection of the education, juvenile justice, and mental health systems and their contribution to the disproportionate number of minorities impacted by the school to prison pipeline. Dr. Scardamalia's research addresses universal prevention and intervention through her work on the development of a classroom-based, modularized social-emotional learning curriculum, and through her research on district-wide strategies to reduce exclusionary discipline practices. Thank you, Dr. Scardamalia and Dr. Bonenkamp.
Absolutely. We're thrilled to be here with you all today. Can you all hear me okay?
Yes.
Okay, good. I'd just like to confirm that. Thank you so much for that introduction. I'm Jill Bonenkamp with the National Center for School Mental Health. And let me just make sure I can move along here. There we go. Our National Center for School Mental Health was established in 1995 with funding from the Health Resources and Services Administration, and we've received continuous funding since then. Our mission is to strengthen policies and programs in school mental health to improve learning and promote success for America's youth. And we do this through research, policy, practice, and training. If you want to learn more about our center, you can start to peruse and find us at schoolmentalhealth.org. I'll be talking through a number of additional resources that our center has that you may want to reference as it relates to this topic and to other things related to school mental health. Our center is co-directed by Dr. Nancy Lever and Dr. Sharon Hoover, and we have a number of core faculty, including Dr. Scardomalia, who I'm so pleased is able to join us today as well. So our agenda for today, we're going to specifically get into some of the nuts and bolts for partnering with schools. And we're so pleased to have you here today as community mental health providers who are interested and enthusiastic about providing services in schools, and recognizing that folks may have a range of experience in that. You may already be in schools. You may be thinking about this, be wanting to pursue partnerships. And so we really want to talk about overcoming barriers, and really we've framed this more of what are some of the very important, kind of groundwork things that need to happen to make sure that you are setting up a high quality partnership that is a collaborative approach between community and school providers. And so we have a number of topics that we'll touch on as it relates to building those high quality programs and collaborative services. One of the most important in any aspect of any new work that you're doing, of course, is this building relationships. And we'll talk specifically about who some of those players are and the roles as it relates to school. And then we'll really be going into much more specific detail about what are some of the school factors that you need to consider when you're going to be providing direct services in schools. What are some of the cultural things that you need to know about school systems? We know that that with every system that we have our own lingo and language and rules and regulations that are governing those systems. And so as we're thinking about going into schools, it's not just a setting where our students are, where we can perhaps have some space, but really we want to make sure we're being very thoughtful in terms of integrating ourselves into those school mental health systems. Our center is able to balance perspectives in terms of coming from both a community mental health lens. So we actually partner with a number of school districts in our state as that community partner to come in and provide mental health services. And so many of what we talk about today will be based on our lessons learned and will be templates and resources of materials that we ourselves use in our practice and have refined our partnership with Baltimore City. It has gone back, I believe, since 1995, and so drawing on a rich history of that partnership to help to share some of those resources with you. And just to keep in mind too, a lot of this information we'll be sharing is the nuts and bolts, and keeping in mind that with any partnership, any new collaboration, anything new that you're getting started with, that the pre-planning and the setting that the systems in place is going to be your most critical piece of this work, and that we really want to help to enable you to have the resources to be able to be very thoughtful around those partnerships, what schools may be thinking, what we've learned from our experience doing this work directly, and then also I'll be sharing examples, and Chris and I will be sharing examples from folks across the country. We're also very pleased, Dr. Scardomalia is a school psychologist by training, and so she's able to, and has provided direct clinical services as a school psychologist in Texas. I'll let her tell you more about that. So to really be able to, help to offer that perspective from the school system in this sense that knowing this information is really critical. So that's too much time on the agenda, but just to set the stage of, why this pre-work is so important. And let's see, I'm having just a delay a second as I'm advancing this. I'm not sure if you can advance that next slide. Great. All right, so I'll go ahead and turn it over to Dr. Scardomalia, who's going to get started with building relationships.
Yeah. Hi, good afternoon. Really excited to be talking with you today. As Jill had noted, I was a licensed specialist school psychology in Texas, in Arlington School District and Austin School District. So we are going to be bringing into this a little bit of the Texas-specific context that comes in here. So the first thing about building relationship is really understanding how the relationship between community providers and school providers can be a good thing. And then from the school perspective, where they might feel some hesitancy, have some questions, or maybe be a little more resistant to involvement. So a lot of your job initially is helping them to understand what you can bring to the table. And am I able to advance slides now?
I'll just go ahead and do it as we go.
Perfect. Will you advance next slide? There we go. Okay. So the big deal is that these partnerships, they can augment the abilities of schools to address mental health in particular, provide a broader array of services and supports, and improve access to mental health care. When you're working with school districts, building these partnerships, the probably most important kind of foundational piece for you to feel really good about and be able to explain to them is that it's often couched as mental health and academics are competing priorities. So getting into the schools, providing mental health services or social emotional learning curriculum, that this is in direct competition with the goals and needs of the school. One of the things that we're trying to help schools understand is that in fact addressing student well-being, addressing mental health in and of itself improves academics, improves graduation rates, and can help them with their goals. If you're beginning a partnership, understanding where why the district is asking for this partnership, why they're open to this partnership, what they're hoping to get out of it, and where their particular district is struggling will help you to align what you highlight about your services to help them see it as this is a support, this is a good thing, this is not going to be a competition. But the big thing when we first start, right, is just understanding what in the world are people talking about. And so why it's important to understand school language and their policy. As Jill was pointing out, there is definitely, we all have our own language and lingo. The pieces that I chose to highlight here are the things that are most likely to come up in your conversations around concerns or how do we make this happen or what do we do about this, right? So in order to be able to engage in practice with schools, we have to understand what the system pressures are that they're experiencing. Let's go to the next slide there. So your school mental health team members can be really quite varied, but generally speaking, you might be working with school social workers, psychologists, counselors, resource teachers, which I think maybe in large part a Texas label, but teachers who are working with students that are below grade level that need, their needs really can't be met in the classroom. So they might be doing small group pullout time where they're helping to remediate academic skills. A lot of times the resource teachers are also leaned on a bit to help support emotional behavioral concerns. School nurses, physical and occupational therapists, behavior specialists. They're called other things in other states. In Texas, they are a behavior specialist, and there is not a specific degree or certification that goes along with that. But they are usually some of your best partners in helping schools understand those, and the school psychologists are helping schools understand how this time kind of out of instruction time toward mental health will be beneficial. And then your IEP team members. So the IEP is your individualized education program. And this is the heart and soul of special education, and particularly for your kids who have mental health concerns and are being served through special education for that. You will often hear a lot about, but the IEP says, and we need to do this for IEP goals. So being aware of what that is. And in schools, particularly lately, it has really become pretty universal to think about multi-tiered systems of support. So a level one is just universal supports. This would be something like a social emotional learning curriculum that all students in every class get. The idea is there's a strong foundation. Most kids who don't have any academic, behavioral, or emotional concerns, they're going to be just fine at a level one. They're going to advance well. A level two is targeted supports. Students who've been identified as being at risk, there's maybe a concern, there's a problem. This is where we're kind of early identifying. You'll start to hear things like, well, you know, we think that counseling might be beneficial to this student. You know, we're kind of thinking of them as a level 2. A lot of schools will refer to these levels as if they're discrete pockets that you live in. And it's really, there's fluid movement through the levels. And we think about all the different aspects of a kid, right? They may be academically, they're good with universal supports, but there's some emotional, mental health issues that they need some help with that rises more to a level 2. A level 3 are your intensive supports. This student needs really individualized services to be able to make adequate progress in schools. And this is a concern that is kind of in full display. This isn't a, we think this is coming, we've seen some signs, there's at risk. The percentages you see there in the triangle is about where we would expect the student population to end up. So we've got about 80% at the bottom, maybe 15% more with some targeted increasing concerns, and that about 5% will really need intensive supports. All of this kind of feeds into RTI, response to intervention. I think this is one of the biggest things that you might hear about as you're trying to start collaborating with schools. Response to intervention is really very simply, if a child is not making progress in some area, it could be any area, you put supports in and you see how they do, right? In a very data-driven way, in a very structured way. But the idea is, you know, universal supports are there. Everybody's got what they need if you don't need anything extra. But maybe, you know, John over here, he's still lagging behind in math. So some targeted interventions to support his math needs. And then you track. Did he, you know, get back up with his classmates and make that progress? Is John still lagging behind? Do we think that John will always need this type of service or support in order to make progress? And there's a second slide also on RTI, right? So this is delivered within that 3-tier framework. This is where these two kind of fit together. So when we think about kids who are being identified as maybe being higher on that triangle, part of what lets school staff know that they're more level 2, level 3 are the supports they need. And it also works the other way. When we start to have concerns, then it's like, oh, we need some more intensive or targeted. These can be provided by a variety of school staff, but the key here is that quite often what you'll hear is that you need RTI documentation before you can move forward for special education evaluation. And you'll hear various levels of that. It is strongly recommended. It is not legally required, but there is a lot of benefit to asking teachers working with a particular student, well, what have you tried, right? The idea being quite possibly the student could make progress with supports that are available through general education, and there doesn't need to be a special education referral. When we think about kids who are having mental health challenges, this piece comes into play quite often. For kids who would eventually be identified as having an emotional disturbance, which is what the education world calls mental health issues. It's a terrible phrase. We will just go ahead and acknowledge that, but it is the legal term that comes out of federal law. So RTI becomes part of, so this child is having some emotional behavioral difficulties. We tried what? We tried small group, we tried social skills, we tried working with the counselor. So one of the things that may come up is, how do school services, how do community-based services occurring in a school building, how are those counted as services, as supports? How is progress documented? Is progress documented? Those are conversations that are good to have ahead of time. And to avoid the situation where you're set up in this school, great, you're building your caseload, you're seeing this kid's in general education, having maybe some increasing behavioral issues, and you've been seeing them for maybe 6-8 weeks now, and then the school decides separately they want to move forward with a referral for special education. and they come to you saying, well, you've been providing services in the school, so you're our RTI. That would be a little bit of a sticky situation to try to then backfill what you've been doing, what you've been working on, and how does that relate to academics. So these are all topics that I would really encourage you to think about and to talk with your school about. What would that look like? I don't know that it's necessarily always appropriate to use your community provider as an RTI provider, but there's nothing that restricts it. So it really is a conversation with your school about how do you feel about this? One of the other ways that I think this can frequently come up is there is a concern on the part of schools. I'm just going to touch base on this very, very quickly because we have a whole section on this later on. There is a concern in the schools that anytime any service is given that would suggest that a child has an individualized need, then there feels like there's an automatic trigger for evaluation and an automatic consideration of special education. So I just kind of want you to put that in the back of your head for now. We'll talk about that when we talk about the child find laws. Okay, I think response to intervention. Yeah. So those are kind of the big systems in schools that you might hear a lot about. It would not shock me at all that you sit down in a meeting with school district leaders and you start hearing, well, you know, we've been working on our MTSS and we really think that this might be a nice tier 3 service. You know, we got to figure out that whole RTI piece. And it's like, I'm sorry, what just got said? What just happened? So MTSS just being this tiered level of supports. RTI simply being, is a kid responding to supports and do they continue to need those supports? And we'll have time for questions on all of that after. So I'm going to toss it back to Jill for confidentiality, consent, and information sharing.
Thank you, and you're welcome to enter questions in the chat, and we're happy to address them, you know, as we're going, or make sure that we get to them at the end. And as it relates to that MTSS structure, community providers, oftentimes we think about first providing those tier 3 services, right, that you could come in and do individual interventions with students or family sessions. In a collaborative, comprehensive school mental health system, oftentimes community partners are addressing needs at all 3 tiers. And so in our Baltimore City model, our clinicians provide direct clinical services, individual tier 3 services, but they're also responsible for tier 1, some tier 1 and tier 2 supports as well. So when you're starting to think about what that partnership is going to look like, I encourage you to think beyond just tier 3, but really to think about what are the needs of the school and how could you potentially meet those across tiers, and what other services might your team coming in be able to help to augment with the school. All right, so I'm going to talk a little bit about confidentiality, consent, and information sharing, because this is often one of the biggest barriers that we hear folks say. And the take home is that it is not an impasse, that you definitely can overcome this with some pretty straightforward systems. But this is a question that school systems may bring and that you as community partners may have when you're thinking about how do we make sure that we're seamlessly collaborating, how do we make sure information sharing is happening. Thank you. And so I would imagine as community behavioral health providers, you're quite familiar with HIPAA. And I oftentimes say that FERPA is a parallel in the education world, in that they're both designed to protect confidentiality. Hospitals and outpatient mental health programs abide by HIPAA, which protects identifiable health information. And then schools must abide by FERPA, which protects the education record. And so I'll be sharing a little bit more about HIPAA and providing additional information, more importantly about FERPA, and where as a community provider you can find additional resources as it relates to FERPA. And then more importantly, how do you make sure that despite both of those federal regulations that information sharing is happening seamlessly between school personnel and community providers. Next slide. So I won't spend much time on this. I'm sure you're familiar with the health insurance portability and privacy rule. There's just an additional link here if you want additional information about that. Next slide. And as I mentioned, FERPA is a federal law that protects the privacy of student education records. It gives parents certain rights with respect to their children's education records, namely that they can review them. And then it also means that basically the sharing of that information is protected. If you want to do, and I encourage you to do some additional reading about FERPA, that's something you can do at this link. There's additional information there. And so the way that many schools get, schools who are partnering with community providers get around this or make sure that their partnering is happening well is through a memorandum of understanding. Your MOU is critical for your partnership across a number of domains. So not just for information sharing, but really critical to be your blueprint of what this partnership is going to look like. You know, what is the purpose of providing services? What will you as a community behavioral health provider be responsible for? What will the school be agreeing to? What will be the roles and responsibilities of each party? You can include both your fiscal and resource agreements. So it may be a number of services, it may be some monetary exchange for service, but it could be resource agreement as well. So space that schools allowing, we have some information around liability as an independent contractor, most useful is that we have a sample MOU. So an MOU that is based on our work in Baltimore City and based on review of a number of other school districts across the country. And we have a copy of that is available in the SHAPE system. I'll talk a little bit more about the SHAPE system, but it's just theshapesystem.com if you want to go and check it out. It's also in the National School Mental Health Curriculum, which is available online and you may have already heard about. We'll have a link for that at the end. As well. So definitely recommend, don't reinvent the wheel. Go ahead and check that out. And before I move on to this next section, just as it relates to confidentiality and the data sharing between HIPAA and FERPA, the most seamless way that this has frequently happened between school and community providers is when the community provider is providing direct clinical services that they have as part of their operating procedure, that a student or family, whoever is providing consent at the time of initiating services, provides a release of information for information exchange between the school. And so basically that way the clinical provider, the community partner that's in the school, excuse me, is able to share with the school, and that they're then able to have information shared back with them by school providers. And this is, you know, an easy step to have as part of your initial paperwork, and really helps to set up that system as it relates to Tier 3 services. When you're thinking about referrals and that process, that's where your MOU is going to be really critical to think about for your specific district, for that specific district, and based on your needs and contractual obligations as a community provider, what language do you need to have in place? And normally this involves having your director or whoever is responsible for some of that contracting process to be involved. But oftentimes, as I mentioned, this is sort of the first thing we hear, that, oh, you know, well, we're not going to be able to share data, or we're not going to be able to tell you about students. And I can tell you that many school districts are doing this well across the country with a couple of extra steps to make sure the groundwork is laid for this. Next slide. So another barrier that we hear and that Chris started to talk on is okay, we're providing some mental health services as part of our multi-tiered system of support. We have school psychologists, we have school social workers, and they're, maybe doing SAL, social emotional learning programs. But we're concerned if we have a community partner coming in, that they're going to be pulling students away from class time, and we have a huge imperative. This is what our mission is. We're not mental health providers. Your schools are not mental health clinics, and so a lot of information and knowledge sharing around why this is a win-win for everyone, and especially a win for schools. That there are so many non-academic barriers to learning, specifically as it relates to mental health. And I'll share some resources in just a moment to help you as you're going into schools and talking with them about that and making the case. But really this idea of better understanding what the school's goals are and how your services and supports can really help them to meet those goals. We've seen a number of ways that different districts have done this really well. So, you can come in and provide services at different tiers to help support students with different levels of need. We've seen districts be really creative in terms of thinking about having their community partner even provide a program that is an alternative to suspension, right? They have students that they didn't want to be having out of school suspension. They were able to partner with a community provider who, instead of students having an out of school suspension, would do therapeutic work with that community provider. And that was a real win-win for them. And I won't go into a lot of details about that, but just to give you an example of how schools and community partners are getting creative to make sure that this really is meeting the individual needs of each school. Next slide. So as I mentioned, these are some of the things that that we talk about when we're talking about school districts as to why have community partners school mental health, why augment services. We know that 3/4 of youth who receive mental health services are already receiving those services in the schools, and that is huge. That schools really are frequently our de facto provider of mental health services. We know that those students who are receiving services in schools are 6 times more likely to complete that treatment in school than in community settings. And this may be one of the reasons, and also related to a number of barriers we know around students being able to get to community mental health services, that you're interested in partnering with schools. That that we know that by having services in schools, it removes a number of those barriers around transportation, parents having to leave work, being able to integrate with the existing system. And so, these are important facts to share with schools and districts. And then these other 2 on our catty corners here are ones that are really critical for schools and are ones that are going to get schools and districts' attention. But positive school climate integrated with social and emotional learning improves school safety and decreases bullying, and that students who participate in social and emotional learning programs improve academic performance by 11 percentile points. And so those types of national statistics and findings are really critical as you're making this case as to why this is a win-win partnership. Next slide. Again, here are some dollars often ring true to folks in both systems, but that school behavioral health is cost effective, that it increases academic performance, attendance, school climate, and is associated with decreases in failure, dropout, suspensions, and expulsions, and parent burden related to getting children to appointments. Next slide. And so much of this about what I've been talking about today, it is not new to schools. And so while there may be some barriers and hesitations that they may speak about, educators and students are saying that this is something that is really critical to them, and increasingly that this is what they're asking for and need and see additional need. This is a report that just recently came out from Child Trends around what do policymakers, educators, and students see as the most critical components to having healthy and safe schools. And across all three of those stakeholder groups, emotional and mental health and school climate emerged as key priority issues that are the foundation to healthy schools. And so again, this is you're not going in with schools, sort of saying what mental health, that there's increasingly a national perspective that there's a real need for this. Next slide. So another barrier or concern or question that we often hear is, well, we already have school-employed staff who are providing mental health services. We have school counselors, we have school social workers, school psychologists, our school nurses are involved in this work. And so oftentimes there can be this concern of, and competing demand of, well, we want additional school counselors or we want additional school social workers. And probably the highest level takeaway is, there is enough work to go around for all of us involved. And I think schools at the end of the day agree with this as well, that we know that there are provider shortages in the community. We know that schools have additional needs as it relates to their student mental health, but it's so critical knowing that perspective and knowing that that might be a concern to come in with that lens. And so not coming in saying, I can meet all of your needs, I'm going to be your number one mental health do all services, but really thinking about what do you already have, asking schools and districts, what does this look like? What are your additional needs? Where could we help to provide additional supports? A really critical place where this happens is around providing those tier 2 services and being able to bill for those services, right? As a community provider, you have those systems in place, and instead of a school district having to create and go through that process, which oftentimes can be a lot burdensome to the system, but that's a strength that you can highlight and bring up. Next slide. And so I'll go ahead and turn it over to Dr. Scaramaglia, who will provide more information and clarify more on MTSS and RTI, and especially as that relates to special education as well.
Yeah, thank you for the question. So they integrate well together, but if you think about MTSS as the structural framework and response to intervention as the services, it kind of helps differentiate the two. So MTSS is simply having a tiered support system where you create buckets, essentially, of this is a universal service, this goes out to every kid. This is something that is maybe done in small group and it goes to a portion of our kids. A lot of times is preventative or kind of early treatment, with that third level being this is a child or a service that is very individualized. The response to intervention is all about the service itself, and in particular the child's reaction to that service. So say for instance, a child starts meeting with the school counselor once a week to work on some issues related to their anxiety. They're meeting for a very individualized concern with a single person. It's not in a group of other kids. So that's really a tier 3 service. The response to intervention would be whatever is showing up in the school as a result of that anxiety that is causing the child difficulty. Did that change or not, based on the provision of counseling to support that? Does that make a little more sense, the difference between the two? And just let me know in the chat box. Perfect, thank you. Okay, so Child Find, which I alluded to earlier in special education, I will say this is where a lot of the nerves come from in school districts. There's a lot of nervousness around this. The primary reason why schools worry is, particularly in Texas, it's a very overworked system right now. Child Find is a law that requires school districts to locate and evaluate every child who has a potentially disabling condition. So from age 3 to 21, it is on the school district to identify kids who might need extra support in school and who might be eligible for special education. This certainly creates a lot of work and some burden on the schools, mostly because we have a fairly significant workforce shortage happening, in particular with school psychologists right now, but we're starting to see that kind of bleed over into school counselors, certainly into teachers, and I can tell you Texas in particular has been fairly hard hit by the school psychology shortage. So there is some hesitation at times, feeling like, well, if we bring in these new mental health services, we open this can of worms where we suddenly discover problems that we didn't know were there, and now we're obligated to do something about that. Now, the do something about that really is to address the concern that has arisen with the child. What you will hear often is that it's taken immediately to anytime we're made aware of a concern, we now have to start testing and do an evaluation for special education. You hear it a lot. There are a lot of administrators who truly feel that's the case. But this is another place you might be able to help and kind of just process through. It's like, you know, as long as you're addressing, you don't have to immediately evaluate. This has become a particularly sticky situation, referencing back to the shortages. The other thing that happened in Texas 2 school years ago, maybe as long ago as 3, is Texas as a state got dinged for having an exceptionally low number of children in special education. On average, the state was hovering around 8%. Typically, it's more around 10%. So there was some fallout from that and things that happened. One of the biggest things, though, is in Texas, if a child has been an RTI, so receiving those structured supports for 6 months or more, or was previously evaluated for special education and found not to qualify, then parents may immediately ask for an evaluation. There are no other services and supports required. There's not a referral process that is required. They can send a letter to the school saying, my kid's been an RTI for 7 months, or they were evaluated last year, they didn't qualify, I want a new evaluation. And a lot of parents have taken school districts up on this. So you can imagine you've already got a bit of a shortage happening. And now you have this enormous increase in referrals. And right now it's a system really struggling to meet those needs and to stay within the federal guidelines. So if your schools seem a little frazzled, they probably are. This is a lot of the reason why. There are some questions around, could community services impact referrals to special education, right? So if I know, because I don't always know if a kid is seeing an outside provider, but if you're providing services in my school building, well, then I know, and then what am I obligated to do with that information, right? So I think helping to draw out those conversations and always grounding it back in, kids can get help from a variety of sources, and it does not mean automatic evaluation. And this gets us to this DSM-IDEA disconnect. I'm assuming, you know, all of us are familiar with the DSM, but when we look at special education diagnosis, which is the last time I'll use that with special education, it's an identification, and it is in no way based on DSM criteria. There are 2 separate and distinct things. And this becomes particularly meaningful when we start talking about mental health concerns. And actually, I'm sorry, can we go to the next slide? I'm getting ahead of my slides. So here's the child find law, right? That schools are required to locate, identify, and evaluate all children with a disability, birth to age 21. Birth to 3, early childhood takes care of that. Your public school district becomes responsible 3 to 21. And I've bolded here, suspected of having a disability, because that's where a lot of the question is coming from. So if I have a community provider in my building and I know a student is seeing them, does that alone mean that this child is suspected of having a disability? When we talk about disability, we'll go to the next slide. This all surrounds eligibility for special education, right? So if a child does have a disability, according to the educational definitions, then they have a right to have a free and appropriate public education that gives them the supports and services that are necessary, not great, not wonderful for them to have, not would be a bit of extra, but are necessary for them to make academic progress. This includes academic, non-academic, and extracurricular aspects of school. So eligibility for special education is determined in two ways. It has to meet two standards. There has to be the presence of a disability, but it also has to adversely impact educational performance. So we can imagine, and I suspect you guys have worked with plenty of kids like this, who are maybe struggling with some early trauma, who are struggling with some anxiety or some depression. But you know, during the school day, they keep it together pretty well. They go, they get their work done, and really nobody in the school building is aware of this. That's not an adverse impact on educational performance. The child can continue to see their outside provider. This does not obligate the school in any way, shape, or form, as long as that child really is performing well academically, right? Versus the student who has their concerns, but is then coming to school and is struggling to get along with their peers, who is really struggling to engage with their schoolwork because that anxiety kicks in and they are highly avoidant of anything that they don't feel comfortable doing. So this is part of the answer to that child find question, right? And is inviting a community provider into my building going to automatically increase my referrals? Well, no, there has to be an impact on educational performance. So kids can go see the community provider, they can work on what they need to work on, but there has to also be an impact on educational performance to trigger an evaluation. What you see listed there are the categories, the eligibility categories in special education. The last one that I've starred, developmental delay, is an allowable category. Texas does not use that category. They do have one they call non-categorical early childhood. And what that is that is for little ones, ages 3 to 5, who you're pretty sure have, or you know, a disabling condition. You know, we're very suspicious of an intellectual disability, we're suspicious of autism, but we can't quite get enough information right now. Maybe the kid just isn't able to fully engage in testing like at age 3. Think about like a 3 or 6 month year old, right? We would often see this with autism assessment when it's a kid who's, you know, higher functioning. The really severe kids on the spectrum are so much easier to identify. But you get those kids who haven't really developed language, they're having some behavior, they really struggle to engage in the assessment. They're not in any kind of structured setting where we can do an observation. So we might say, you know, I really think as this progresses, we're probably gonna feel a lot more comfortable that this kid's on the spectrum. For now, I'm gonna say non-categorical early childhood with a suspicion of autism, because that allows entry into special education, it allows services and support to be given, and then we make up our minds after 3 years of services and supports and interventions. Emotional disturbance is on here. Yep, that is where we need to go. And I really wanted you guys to see this, because when we talk about the disconnect between DSM and IDEA, I don't know that it's any more obvious than in this particular definition. So for a child to meet eligibility under emotional disturbance, this is the sum total of the criteria. That A through E, they need to meet one of those 5 criteria as determined by the child's IEP team, right? So you take something like an inability to build or maintain satisfactory interpersonal relationships. Fairly vague, not a lot of direction, inappropriate types of behaviors or feelings under normal circumstances. So this is what the school is looking at as mental health concern, emotional disturbance, or not. A student may have a DSM diagnosis and not qualify. as ED. A student may be qualified in the school as having an emotional disturbance, but not actually meet criteria for any DSM diagnosis. This is another one of those kind of misconceptions out there that if a student has a DSM diagnosis, it's an automatic entry into special education. And that's not the case for both reasons that we identified earlier. They need to meet this definition of ED. Granted, it's vague enough. It's you know, you can almost fit anybody into this definition that you want. But you also have to have that adverse effect on their educational performance. Okay. I get horrified every time I look at that definition, by the way. So all of these laws and rules surrounding child fines, surrounding eligibility, these are just a bunch of different areas where you can find guidance. There's the Texas Education Code. That is kind of the holder of the state regulations of how they've interpreted the federal law. Texas follows the federal code fairly closely. There is the TEA distributed state laws and rules that is more focused on education alone and how that is, how we take the laws and actually do that in the schools. The Educational Service Center Region 18 has specifically a legal framework that gives a little more guidance to practitioners, to parents about, again, how these laws and rules are handled in your school buildings, and then state guidance documents related to special education. Because as with the eligibility for, like the eligibility statement for an emotional disturbance, just because we have these laws and these rules doesn't necessarily mean they're terribly clear about what needs to happen on a case-by-case basis. So these are some resources for you. So I'm just checking my notes and making sure I hit everything I wanted to. Those are some resources that you can look at. The one thing I did want to touch on just from a moment ago is what we mean by IEP goals. So for any student who is found eligible to be in special education, they have to have an individual education plan. And so these are the things that are absolutely necessary for this child to have to be successful in schools. Some of that might include counseling with the school counselor, or counseling to work on social skills, counseling to work on being able to speak up in class, things like this. The school counselor, if they're seeing a special education student and the student's receiving special education counseling, the counseling has to be related to the goal, and the goal has to be addressed through counseling. So we earlier referenced, could a child have a school counselor and work with a community health provider? Sure. There is oftentimes a very clear division of duties there. So the kid who it's just not getting along well with other kids in class, who's constantly defensive and arguing, and they're getting the class off task and they're not getting their work done, right? The school counselor may be working in a very targeted way on those peer relationships and helping the child to just build the skills to get along with others in class. Now, as a community provider, you may know that all of this is stemming from disruption at home, maybe some early trauma that this child has experienced. And you then can work with the child on all of these big background issues. Those two are not competing tasks or priorities. But just to be aware of, if you hear, well, they have to see our counselor because there's IEP goals to be met. That's what they're referencing. Okay, so yeah, these are legal resources, and then I'm gonna let Jill talk you through the remainder of the resources in the slides.
Thank you, Chris. And just so you know, we don't anticipate or expect, or nor do school districts expect you to be specialists in understanding special education and that there and child fine, and a lot of nuances, as you may have heard, that here that are related to that. But we wanted to give you an introduction to that and some context as you're coming into schools, that may be a barrier, something that schools are thinking about, and something you may want to bring up as you're doing that planning work and making sure that as you're pre-planning, as you're getting things in place, that you've really thought about some of these different things that may come up. And it may be, we've seen in different partnerships that it may be that you're just working with general education students, and that school counselors, school psychologists are really targeting students who are in special education. We've seen districts do this differently across the country. I'm going to run through now a couple of other resources. This is a 1-hour primer to get you started thinking about key nuts and bolts as it relates to school community partnerships, but we have a number of other resources. So this first one is on mdbehavioralhealth.com. It is a full training series, about 8 hours of content in an interactive format here, just around this topic. So how do how do community mental health providers partner with schools around providing mental health services, and what are some additional resources and knowledge and pieces that are critical for this? This is a free training available online nationally, developed by our National Center with other partners. Next slide.
And I'll send these links to all the participants after the webinar today.
Great, thank you. So I hope that you have heard about the National School Mental Health Curriculum as part of your MHTTC work, but if you are just joining this series, in partnership with the MHTTC centers, our National Center for School Mental Health has helped to develop a national school mental health curriculum. It is now live on the MHTTC website. I am referring to it as an encyclopedia of school mental health. It is chock full of resources. As I mentioned, the sample MOU is on there, all available for you to be able to reference. There's a whole section on teaming that really has a number of resources as you're thinking about how do you set up those collaborative relationships. So highly recommend that you check out the website and the curriculum, and in particular teaming. As I mentioned, another resource for you is the SHAPE system. The SHAPE system maps closely to the National School Mental Health Curriculum, and it allows schools and districts and states to map their current mental health supports and services, both school-based and community partners, assess their system quality. It provides customized reports, and provides a number of different resources. And this is a critical tool for you to think about as you're establishing those relationships with school districts, that these assessments and these resources are things that you could do in partnership with schools to make sure that you are providing a comprehensive approach and thinking about, are you making sure that you're really being collaborative in terms of what community partners are providing and school systems are providing. Next slide.
We have about 1 minute, Jill, so I just want to let the community know I've added links to the chat box.
Appreciate it. We also have a school mental health teaming playbook that has a number of resources specifically as it relates to setting up these partnerships, collaborative approaches, has some examples of informed consents to allow information sharing. You can check that out on our Center for School Mental Health website. Next slide. And probably most importantly, you may have also heard about this through your MHTTC and through this series, but we are so thrilled that this year our National School Mental Health Conference will be happening in Texas, in Austin this year. This is a national conference that brings together schools, districts, community partners, folks who are doing comprehensive school mental health for 3 days to talk about all things school mental health. So if you want an intensive learning experience around how other schools and districts are partnering, how other community partners are augmenting services, what this looks like, and connecting with other folks in the field in Texas and across the country, highly recommend, and especially since this is happening in your backyard this year, and we're so thrilled to be coming and partnering with the Texas MHTTC as it relates to this work. I'm sure you'll be receiving additional information about this next. I know we are at the top of the hour. Please feel free to type in any questions, and we're happy to stay on and answer those. Our contact information is also here. If you're interested in staying connected with our center, recommend that you sign up to receive our listserv. We send announcements out about every month. You won't get inundated, but just so you'll hear anything taking using the resources as it relates to comprehensive school mental health.
Okay, thank you so much, Dr. Bonenkamp and Dr. Scardamalia, for leading our webinar today.